this one meta message that in our patients, and I know that sitting in the room here are not only researchers but also clinicians, in my meta messages in working with our patients with addictions, if we do something to address their sleep difficulties, our pathway to their recovery, from my point of view, will be enhanced. So I thought us taking a look at what are some of the commonly used sleep medicines and are they always necessary, because I run an insomnia clinic on Mondays when I'm not here at the conference, and I'm often asked by the insomniacs about various medicines to help them to knock them out and then to help them to get through their day and these kinds of things. And on occasion, we'll be doing needs assessments and intake interviews of patients that are seeking something to help them get through the day, which is really part of a picture of their substance use condition that they're involved in, unfortunately. So sleep, starry night, and the ways in which we think about it. It's very much a necessary component for good health to get a good night of sleep. For an adult, 7 hours and 15 minutes. The weekly average sleep duration by health status is presented here on the screen with general health represented by these the bars here, with the values endorsed for excellent, very good, and poor being in that lime green color. Quality of life, physical health, and mental health. The percent rating sleep quality as good or very good by health ratings is quite low, or there's unfortunately a high amount of individuals still that have fair or poor general health that also have poor sleep quality. So it's part of your therapy and treatment, part of the recovery plan should be something like this. We also know that there's more accidents, car accidents. This just details from the Department of Motor Vehicles that it takes 2 seconds to cross over, roughly a lane a second, when someone's sleepy, secondary to undiagnosed sleep apnea or insomnia. So they're at risk for also if the highest rate of motor vehicle accidents that involve an outside substance is alcohol, and then second to that, the second one on the list is sleep deprivation. So we're already working with substance problems with our patients, so adding this as one more component is sensible. Typical night's sleep is depicted here. They're falling asleep after an hour and a half, a REM episode. We have 4 throughout the night, and we get about 60% of our sleep is stage 2 sleep, physiological sleep, and we get our necessary optimal deep sleep at the first part of the night. Our patients that are recovering on your units that you're running and directing or in your practices are having fragmented sleep, so they're going to sleep and then waking up, and they have to start this cycle again, and so that results in a loss of the sleep that is obtained at the end of the architecture here at the end. Sleep is determined by 2 factors: how sleepy you are. So sleep demand, Borbolet's original research is represented here in the top graph, so like a rubber band being pulled back in a slingshot. We wake up at 7 a.m., hypothetically, and our sleep propensity, our need to sleep, grows throughout the day until a time roughly around 11 o'clock. We feel sleepy enough to fall asleep. That has to co-occur with our natural rhythm on the sleep-wake cycle of what it's our time, our bedtime to sleep. And if those 2 variables are aligned, then we fall asleep and we have this regular sleep pattern. Sleep pattern matures between 17 and 19 years old. I work with research a lot with undergraduates that are college students that are quite susceptible to ruining and distorting their sleep because of their position in life and their philosophical view that sleep is for later and fun is now, this kind of motif. And so I'm forever working with them on trying to get them to think of more sleep health. The components within our brain, the cluster of nuclei in the suprachiasmatic nucleus, our pacemaker cells, much like in the myocardium, will regulate sleep. and they are turned on and are influential when a person gets enough bright light. So for some with seasonal affective disorder, as you might know, people will respond to bright lights, and some of our antidepressant medications are not helpful. We also know that co-occurring during these cycles of sleep, we can count on different ranges of hormonal levels, like plasma melatonin is released after that first hour and a half, and that's something that sets the circadian rhythm. Core body temperature is lowest at falling asleep and staying awake, that we see here. And at night, our plasma cortisol is heightened, especially during that last epoch, right before a person wakes up about 5 o'clock. So the key findings with other components related to health, as we should be noted of in taking care of our patients in this substance use conditions, is that worse health and stress are also associated with many more pain conditions. There was an article, a little tidbit in the USA Today, that 1 in 5 Americans are on Social Security disability income. Did you see that? And it's estimated in that little tidbit that about 38% of our population is meeting one or more criteria. So this pain is usually one of the components, and obviously the others are medical illness or disorder. Sleep and psychiatric disorders, more germane to what we're talking about today. Poor sleep, insomnia, is predictive of an onset, if someone is symptomatic, for an episode of a bipolar disorder, with post-traumatic stress disorder, for an episode of the catastrophic stress and duress that's felt, and other components. In short, symptoms are worsened and increase in presentation when a person is susceptible due to secondary to poor sleep or sleep deprivation. The decrease in resistance to infectious diseases there, the chronic septic state, eventual lethal bloodstream infection is a more proximal cause of death. So we see these kinds of conditions in rare situations. But actually in Chicago, one of the original authors of the guide to how to score sleep, Dr. Rex Chafin, did preliminary research looking at the onset of illness in animal study subjects, as we're to call them now with the APA standards, right? And these turtles that were sleep deprived for days ended up developing all sorts of skin conditions and infections due to the extreme loss of sleep. So incredibly important for that stage 4 sleep, for the co-occurrence of immune system, releasing of cytokines and other necessary cells for us to be able to sleep better. Pain is also associated, as I mentioned before, more sleep problems we see. So weekly sleep depth by pain type, no pain, acute pain and chronic pain, we see a double increase. And to our right, the sleep quality by pain severity, pain ratings are higher in this lime green coloring here, good to very good. In individuals with mild pain, moderate pain, that drops a bit, and of course with severe pain drops even further. So the impact of sleep difficulty by pain type, we're seeing it in terms of chronic pain, higher numbers in terms of related to settings in work, and the impact of sleep difficulty by pain severity, the percent with interference in each activity. Again, here we see it in terms of work-related variables. That data comes from large-scale collection from the National Sleep Foundation. Medical illness and sleep disorder, odds ratios show more than 2 times the episode of event for depression or lung conditions and obesity and breathing problems when an individual has poor sleep. Foley's study also identified those that are twice or 2 times more at risk for stroke, depression, and body pain with excessive daytime sleepiness. The percent reporting difficulty sleeping often or always due to other factors by pain type, and highest on this list here, the region of working in this zone here, the way in which the person is experiencing their pain at this chronic pain level. Here I present to us from, this also is from the National Sleep Foundation, large sleep duration and better sleep quality were associated with also better health. And we see these values with the excellent ratings corresponding to general health. And over here again, percent saying very good or excellent quality of life by sleep quality in this first one on our far left. Stress levels by pain severity are heightened and by a moderator of poor sleep, severe, very severe pain in those conditions with high stress and also poor sleep. What about napping? Is napping good? Maybe not for these gentlemen. Perhaps they're very skilled, or these young ladies. But napping is, as long as it's a power nap before the watershed time of about 4 p.m., it won't affect this night's sleep that we're preparing for. So I always tell our patients to make it as efficient as possible and early as one can. In fact, colleagues at Stanford, Malzak and some others have identified, and they have a little chart, much like the charts that obstetricians and gynecologists will use to predict pregnancy with the dates on them. They'll look at timings, amount of sleep the person gets, and it's a little wheel that they dial to tell you, well, this is the optimal time for your 30-minute nap. And they have it by age and by bedtime and amount of sleep that you typically get. So it's come down to that with some of their results from their regression equations. When we sleep and when we don't, there's differences in brain activity, your brain on sleep deprivation. Notice the paucity of activity and low level of lighting. Pain, health, and safety, as I mentioned before, more sleep depth, higher chronic pain. Percent of impact of sleep difficulty by pain type, great deal, quite a bit, or interference we see more so with work, probably secondly by a compromise in quality of life. Difficulty sleeping often or always is due to environmental factors, and we see that as, again, quite high, and they're rating that with that mattress. Maybe that's why some of those commercials are trying to rake in some money using those kind of variables. Germane to us here in the room as researchers and treatment providers to individuals with substance use, addiction problems. Withdrawal syndrome, untreated insomnia, sleep disturbance threatens the recovery. Brower in 2007 reported increased number of arousals, sleep fragmentation, wake up, fall asleep, wake up, fall asleep. Only get that light stage 1 sleep from my little histogram about 4 or 5 slides ago. Decreased REM episodes. REM is a time for information processing, for consolidation of memories, and a lot of the type of perceptual and organizational kind of processing of information that we know of. And when we're robbed of that, we don't have that opportunity to operate in that regard in the day. Diabolical studies by colleagues in my field testing individuals that have been denied REM sleep have difficulty with cognitive tasks that involve divergent thinking, using more than one alternatives, being creative, taking the initiative, leadership roles. So anything in which there has to be a self-initiation and carry through is something that is socially too and personally too taxing to the person that's REM deprived. Breathing disorders as well. Cocaine withdrawal effect, hypersomnia, excessive wakefulness. Those of you providing treatment see this in your patients and prescribe perhaps the Ambien or maybe Sonata as a short-term hypnotic to help with them to fall asleep perhaps. Marijuana withdrawal effect, we see REM suppression from a cluster of studies in this area, and insomnia. We have a neurobiological vulnerability with poor sleep, the adrenocorticotropic hormone that we heard about in the previous presentation, and cortisol plasma levels directly correlate to childhood trauma and high stress levels, and it's reported to be involved in vulnerability to alcohol and drug dependence in individuals. So the susceptibility we heard in the previous presentation is also relevant here because it places a person in a role that's also joined by being susceptible to poor sleep. Behavioral non-pharmacological treatment works. We heard about CBT as a treatment modality for taking the treatment plan for your patient with an addiction, but at the sleep focus, insomnia, scheduled naps for the hypersomniac or narcoleptic, the sleep apneic, that 60% of cases of sleep apnea also have insomnia. The longer they wait to get diagnosed, the more often they're going to have the insomnia as well. So these techniques of the CBT that we see in those treatment modalities we do now are also germane to doing this work with insomnia and sleep-related disorders. With our alcohol-dependent disorder, we're talking about using DSM-5 language. 4.4 out of 10 nights on average report insomnia by one researcher. A second researcher with an all-night polysonogram of patients with addiction diagnosis versus controls found that those with alcohol use, there was a decrease in slow wave sleep, total sleep time. With opioids, REM was suppressed out of the picture, and controls, we didn't see those findings. With depressed, increased onset or early arrival of rapid eye movement sleep, and increased wake after sleep onset. So a person wakes up, and usually you wake up 4 to 5 times during the night momentarily. You may even sit up and ask, what is that noise, that refrigerator motor that turns on or something, and then you flop back down to sleep. We're talking here when an individual is awake and comes more out of the altered state of consciousness of sleep and is awake for a number of minutes. And so we see more WASOs in individuals that are depressed. The FDA-approved drugs, benzodiazepine receptor agonist, melatonin receptor agonists like Rosarim that works with M1 and M2 receptor sites. Drugs that are used off-label, not FDA approved for insomnia, like sedating antidepressants. Some you might see would get a prescription of either Prozac or Zoloft. And antipsychotics, I think the one that's always the popular one I see on charts when I'm reviewing is Seroquel, when they're using it in that off-label manner. Self-medication, our patients come to us and they're using alcohol to self-medicate, as well as taking over-the-counter sleep aids. I did a Google search, right? Why not? Google search for everything. Google search, what are the over-the-counter medications for sleep? I thought I'd get, page, and it would tell me the usual culprits we all see. 6 pages, single-spaced. That's how many, we see the commercials for Prosom and extra strength Tylenol for sleep and Z and all of this. Well, that list went on and on and on. I had no idea that it was that extensive. So our patients are waiting to see us because of insurance, or they don't want to take ownership of their condition, or a whole cadre of different reasons, and they're going to the local CVS or Walgreens or drugstore, and there's this whole inventory of possibilities. And then there's the herbal remedies, the lavender, or the different substances that they can take, or different types of vitamin combinations that are being done. Ethanol, 21% using, results in tolerance with chronic and diminished sleep efficiency and quality. So it's we teach this, and it's part of the educative component of your treatment programs, I'm certain, that it's a central nervous system depressant, so it knocks the person out. They think that's what's helping them to sleep, but really what it's doing is shortening and lightening their sleep, and most of the effects are irreversible. So they may get sobriety from your wonderful care and treatment, but they never get back their nice sleep that they once had as a 30-year-old, 22-year-old. So over-the-counter sleeping pills contain sedating antihistamines, as well as some other things, diphenhydramine and daytime sleepiness, cognitive impairment. Some of the anticholinergic effects, dry skin and dry mouth, some of those are distracting, and we see, for example, the change in the lens of the eye with the dryness could lead to some of the driving performance impairments. Herbal agents, I talked about tryptophan. Kava is abused in some cultures, but it's something that's popular among young adults. I teach graduate course in psychopharmacology, and I give them a leeway to do a project, and there's always a group, a team that wants to report on kava kava, and they find a subculture within a Chicago neighborhood where you can buy, a 1-gallon jug of kava kava tea, and they talk all about it. So it has its place in popularity, and it's mildly sedating, but we know it from our educative and medical perspective as being a toxin to the liver, hepatic toxicity. So here are some of the commonly used medicines per my title. Trazodone, zolpidem or Ambien, amitriptyline, so using a low dose at hour of sleep of an antidepressant, tricyclic. Going down the list to Temazepam, Quintiapine, Zelpion, Sonata. One of the nice things about Sonata, it has a shorter half-life than Ambien, so oftentimes the prescription is to include, if you know that you wake up, it puts you to sleep, but you wake up and you know that you have 6 hours before you have to be to work or school or up to take care of your children, something responsible, you can take another pill because it has about a 4-hour time span. So that's one of the popularities there. The list continues on the other side. This is what we run into, and I think you might see it at your treatment facilities you direct as well, is that the use of benzodiazepines are common, Xanax and some of the others we see on the list here. And with that, it invites their withdrawal, which is compassionate and necessary, perhaps, a prescription of a benzo. But at the same time, then you have homework for later to do the titration off the benzo, which is not always the easiest thing to do. Writing the titration plan and planning it is easy. Helping the patient to cooperate and stick with it is tough business, and I know that you probably work through that. Medications known to cause insomnia. The other thing about commonly used medicines, some of the things that your patients might be on as they're going through their recoveries and treatment for other medical conditions that they're on might be some of the reasons for their sleeplessness or fragmented sleep. Some of the antibiotics, quinolones, if they've traveled or have a really terrible infection, might be on that. Anticonvulsants, antihypertensives. By choice, having the venti, it's like the big gulp with 2 hands from Starbucks of caffeine, so huge amounts of caffeine they might be drinking, unfortunately. Decongestants, diuretics, lipid and cholesterol lowering agents, niacin, if some of the diazods or some of the other, if they have a cardiovascular problem where some of the first line meds aren't working, they might be on niacin, theophylline, and thyroid preparations. So what do we see? Work by Dr. Ankoli Israel recently with Dr. Roth in Detroit looked at the percent of patients using over-the-counter alcohol or both to be able to sleep, and it's quite common for our patients to select those. Ohanyan and Belter took a look at the duration of hypnotic use, and if it's less than 5 months, it's our burgundy color here, greater than 5 years. At the sleep clinic that I'm at, we will use Ambien or a prescription of other hypnotic medications as the need for that individual patient dictates. Now, the medication, the little origami folded box, paper that comes in the box with it, clearly says from the clinical trials that it should be 12 to 14 days use only. But there's usually a pattern use that we use. Neurological targets for pharmacological development, wake, norepinephrine, serotonin, acetylcholine, histamine. And when we're talking about the sleep medicines, areas of investigation are looking at adenosine or GABA, galantin, and melatonin as additional areas to develop sleep-related medicines. GABA medicines, 30% of all brain synapses use GABA, so that's probably why there's the popularity of the benzodiazepines, because they use a portion, the receptor site on the GABA molecule, controls the flow of chloride ions and slows down the receptivity. So sleep is dictated by in the Ralph nucleus for cells activating rapid eye movement sleep, and in the locus coeruleus, activating non-REM sleep. When REM sleep is occurring, the RAF nucleus will also send pulsations from the pons to the geniculate nucleus and back to the cortex of the brain in what are called the occipital region, what are called pogo waves. And so the visual and emotional aspects of dream sleep are literally from our brain being stimulated in those areas. So some of your patients, as they're recovering, might have trauma related to the addiction, the condition of that. And so knowing as they're getting better and sleeping better, and their dreams and sleep will return, so too will the duress of their experiences. So nightmares or sleep terrors, confusional arousals perhaps might be something you'd be seeing. Just the list again for just benzodiazepines alone, FDA-approved hypnotics are here. These are really non-benzos, the Ambien and Sonata that are on the list here. Sleep onset latency to persistent sleep. Using Ambien, just the starting dose, 10 milligrams, we see at baseline, and by the second week, there is a difference between placebo and the control group with shorter number of minutes to sleep. It should be about 15 to 30 minutes to sleep, so both of these groups are above the norm here. Dose response effects for the polysomnography efficiency variables in terms of the mean change from baseline for using Salamum or a type of prosome. There's a formulary of that's sold over the counter now. And we see reductions in the wake after sleep onset, increases in total sleep time, and reductions in sleep latency, or the amount of minutes to be able to fall asleep. I think I'll use this as my last slide. The rebound insomnia will occur when an individual is able to come back to having a sleep pattern after it's been interrupted by their addiction behaviors and sleeplessness secondary to what's going on. And it'll be exacerbation relative to the baseline. There'll be 1 to 2 nights of duration. Withdrawal syndrome, you'll also see this return of this early original symptoms at basal level severity and complexity of symptoms will reoccur, and they'll be at a longer duration. So when a person is recovering, we also have to look at their sleep quality and the return of some aspects of sleep as it might disturb them. I think that's the one I want to, I will stop on this one. This is one that was made mention of earlier, that sometimes the antidepressant medications are used as sleep aids when people are in a medical condition or recovering in some way. It's common but now not well studied that the treatment of insomnia in patients with depression. They're not FDA approved for insomnia, but sedating antidepressants are commonly used. Probably the top of the list, as you've seen from your work too, is Deseril or Trazodone, quite popular. And I mentioned earlier that 100 milligrams of Elavil or amitriptyline at hour of sleep is also a very common agent that's used. Doxepin's kind of old, Sinequan, and Remeron, we'd probably see that in a more of a managed care facility, like here in the States, perhaps a residential facility where that might be on their registry. So in conclusion, I've gone through some key studies, focused areas by research by the National Sleep Foundation, Sleep Research Society, to highlight the point about the importance to our health of sleep and also to the health of our patients as they're struggling with first a diagnosis and parts of treatment and recovery from whatever their addiction is. The literature has numerous examples of where we see by type of substance that's being abused and compromise in sleep, but in general we see one or more of these important variables that we are measuring being reduced to one level or more. And I made a statement earlier about ethanol abuse, alcohol abuse, that the sleep recovery is irreversible, and that is true. It's not so much the case with what we're seeing with some of the studies with opioids and cocaine, but the recovery to sleep is taking much longer, going from months to almost a calendar year. So in your treatment plans accordingly, having one of your counselors work with sleep hygiene, CBT for sleep problems, and having some sort of follow-up as long as a year out might be something that, if you don't already have it, something to possibly consider. Thank you for your kind attention, and I hope I got us back on schedule.